Okay, good afternoon, everyone. Welcome all of you to Meet the Expert, Heart Failure, LVAD, and ECMO. For sake of time, I will start with the first topic. First topic is a safer operation for low EF patient. Current strategy. We're gonna have a video from Dr. Tong. Okay, you can turn it on.
Dear friends and colleagues, it is my pleasure to be speaking to you today. I would like to thank the ASCVTS and to VSAC for the kind invitation. My talk today will be on the safer operation for patients with low ejection fraction and the current strategy at Cleveland Clinic to get these patients through surgery. I'll be talking about the preoperative assessment of patients with low EF, including ischemic cardiomyopathy and valvular cardiomyopathy, the surgical considerations for these patients and how we conduct the operation. We will talk about our LVAD backup strategy, as well as a case that will tie together the concepts that I will be discussing. Coronary artery bypass and coronary disease as pioneered by Mason Sones and Rene Favalaro was first described in a large series back in 1970s, which demonstrated for the first time that in a large cohort you can have good outcomes with coronary artery bypass for patients with a coronary artery disease. And over time, we know that the more advanced the coronary disease, the more dysfunctional the myocardial infarction, the more patients are able to benefit from surgery. The STICH trial also was a large study with patients with the EF of less than 35%, and patients were randomized to medical therapy alone or medical therapy with CABG in the hypothesis 1 of the STICH trial. And it showed that patients who underwent a CABG had a 21% reduction in their primary outcomes in patients who had CABG at 10 years. However, because of the perception of the high incidence of post-cardiotomy shock and a higher risk of morbidity and mortality associated with these patients, there is still some hesitancy to proceed with surgery in patients with low ejection fraction. However, what I want to show you is that these patients are not patients that you need to be afraid of, but rather patients that you should embrace, because these are the patients that you can make the greatest impact on their survival and on their symptoms. Let's consider this following patient. This is a young man, 47-year-old, with a history of diabetes and hyperlipidemia and presents with CHF. You do the coronary angiogram, which shows an 100% occluded LAD, 100% occluded RCA, a 70% OM1 and 99% OM2 lesion. On echo, the EF is about 15%, the RV is moderate, and you also have 2+ module regurgitation. What are the options for a patient like this? We can consider CABG, PCI, or just medical therapy, or we can consider transplant and LVAD. When I evaluate these patients, the first thing that I look at is the quality of the coronary targets. We also want to assess myocardial ischemia viability, assess the degree of cardiac compensation or decompensation, and the overall patient's conditions and symptoms. Coronary target is by far the most important determinant of outcomes, as a figure on the left shows a patient who have a very good coronary targets, whereas the patient on the right have very poor runoff and unlikely to improve significantly from bypass. Assessing the myocardial ischemia burden and the viability is equally important. When patients in the presence of coronary disease will experience a stunned myocardium, and with repeated ischemia, the stunned myocardium will become hibernating, and with persistent repeated ischemia, you will lead to cell death and myocardial scar. Therefore, when we test for myocardial viability, the two things that we're looking for is on a physiologic level, we want to look at the perfusion, metabolism of the myocardium, as well as contractile reserve. And on the anatomical side, we want to look for presence of scar, as well as the thickness of the myocardium, as well as the size of the total ventricle. These are some of the tests that can be used to assess myocardial function and viability. And the two tests for viability that we use the most often in Cleveland Clinic are the PET scan with FDG as well as MRI with gadolinium. In a normal myocardium, you expect a normal perfusion, normal contractile reserve, normal metabolism, and no scar. In the stunned myocardium, you would expect the same. In a hibernating myocardium, however, the perfusion and the contractile reserve may decrease, but the metabolism will still remain the same, and you will not see scar on the MRI. However, once you have myocardial scar, then the metabolism will drop, and you will see scar on a gadolinium enhancement of the MRI. If you then look at the total burden of myocardial ischemia, if you have a total of 60% of the LV mass that is potentially viable, then in that case you can go to the operating room with reasonable confidence that this ventricle have a good potential to recover. Some of the other considerations that we may have are the right heart cath. We will routinely perform a right heart cath on all of these patients, and we will look for a cardiac index of 2.2 to give us a good indication that the patient is well compensated, and also assess the right ventricular function using the pulmonary artery pulsatility index, or PAPI. To calculate the PAPI, you take the PA systolic minus diastolic and you divide it by CVP. And if you have a PAPI of greater than 1.5 and certainly greater than 1.8, then you have good confidence that the right ventricle function is adequate. For example, if you have a patient who has a pulmonary artery pressure of 65/25 with a CVP of 10, the PAPI is calculated to be 4, and this will be a very good ventricle. Versus somebody who has a PA pressures of 35/25 and a CVP of 15, the PAPI in that RV is calculated to be 0.7, and this patient you would expect will struggle with the right ventricular function following surgery. Looking at the left ventricular size, 6.5 centimeters seems to be the cutoff where you have compensation or a decompensated left heart. And this study out of the Netherlands showed that the survival was much different when you have a left ventricular end diastolic dimension of greater than 65 millimeters. However, this isn't the only thing that we will assess, of course, and it's just one of many parameters. Also, the patient's comorbidities and their functional status. If you have a patient who's coming to the clinic to see you, who's walking into clinic, they're going to have a much better outcome compared to a patient who's in a balloon, intubated on a balloon pump in the ICU on multiple drips. Next, I look at symptoms. Patients typically, if they have angina symptoms, it suggests that they have viable myocardium that's at risk. However, patients who have shortness of breath as their predominant symptoms, this is a sign of a more advanced heart failure. At the time of surgery, it's important to make sure that the patient are as medically optimized as they can going into surgery. You do not want them to be in decompensated shock. If there are times where patients are decompensated, and we would rather put a balloon pump or put a temporary mechanical device to stabilize the patient, have normal end organ function before going to surgery. We aim for complete revascularization, and cardioprotection is also something we pay great attention to. We'll give antegrade and retrograde cardioplegia for all these patients. I prefer to give Buckberg rather than Dalnedo in the presence of coronary artery disease to ensure that you have an even cardioplegia distribution in the myocardium. I'll typically give a liter of antegrade and 500 of retrograde as an induction, and 500 mils of retrograde and down grafts every 15 minutes, followed by a hot shot before taking off the cross clamp. Postoperatively, we are very aggressive in placing balloon pumps and Impella devices whenever they're needed. Long term, we want to optimize the medical treatment with heart failure specialists, and will routinely follow these patients at the 6 to 12 week mark following surgery and down the road as well. Now, looking at our LVAD backup strategy for these patients, this is something that we've established over the last 3 years. In patients who are at high risk of intraoperative cardiogenic shock, these patients, we will undergo abbreviated heart failure workup for LVAD, and this entails evaluating them for their insurance and getting approval for LVAD insertion. We will do LVAD education with these patients and consent them for LVAD backup. as if the patients do not recover from their standard surgery, then we may need to progress them to an LVAD, and it's much easier and much better accepted by the patient if you do that education and do the consent process upfront rather than on the back end once a patient is in cardiogenic shock on ECMO coming out of the operating room. To prepare for these cases, we will routinely open the axillary artery and place a 10 millimeter graft on the axillary artery. This will be used for an Impella insertion if needed after we come off bypass if the patient is in shock. So looking at our experience in the last 2 years at the Cleveland Clinic, between myself, my colleagues, Dr. Soltesz, Dr. Unai, and Dr. Bikin, we performed 193 cases with an EF of less than 35%, with a mean EF of 22%. Out of these 193 cases, we identified 55 of these patients who we felt were at high risk of developing cardiogenic shock post-op. And out of these, you have a smattering of patients with isolated cabbage and valves or isolated valves. Among these 55 patients, the mean age was 64. The median LVED, it was 6.1 centimeters with 22% above 6.5 centimeters. And pre-op, 1 patient was on an Impella, 2 patients were on ECMO, and 13 patients were on a balloon pump. This was a high-risk cohort of patients. Post-operatively, out of those 55 patients, 9 required an Impella and 8 required a post-op balloon pump. We only had 1 mortality and 2 strokes in this entire cohort. And when we followed up these patients and looked at what happened to their ventricles, the ejection fraction improved from 22% pre-op to 29% at the time of discharge and to 36% at 6 to 12 weeks post-operatively. So back to our patient, the 47-year-old with CHF symptoms. We performed a right heart cath for this patient. His PA pressures were 65/30 with a right atrial pressure of 11. This calculated to a PAPI of 3.3, which told us that the right ventricle function was good. The cardiac index was adequate. This is the preoperative echo. We also performed a PET, which showed that the only area where there was scar was in the LAD territory, and the burden of scar was less than 10%. Therefore, the overall LV mass that was viable was over 90%. We performed a 4-vessel cabbage with bilateral memory. The Impella was inserted and removed on postoperative day 1. Patient was discharged on postoperative day 8. And on 8 weeks after surgery, the ejection fraction had improved to about 40% with normal or low normal right ventricular function, and the MR had improved. So with preoperative planning and preoperative assessment of the patient and the heart and the ventricle, as well as intraoperative planning and complete revascularization, good myocardial protection, and good postoperative optimal medical therapy, with the addition of a possible LVAD backup, we can achieve excellent results for these patients and make a dramatic improvement to both their survival and their quality of life. Thank you very much.
I would like to proceed with the next topic and then left the question and answer at the last. Okay. The next topic, I will be present the ECMO for non-cardiac cause indication and result. So the topic is all about the non-cardiac cause. I'm gonna be focused on the lung respiratory condition rather than the cardiac. Okay. Okay. The first ECMO actually put in the a man, 24-year-old man with a bronchostoma, which is he has the shock lung, so it's just a non-cardiac cause for the first case of the ECMO. And this man on the VV ECMO for 75 hours before he fully recovered and discharged. But the question is, at that time is, if this man gonna be survive even if the ECMO do not put in at that time. So at that time, they have a randomized control trial to answer this question. It includes the patient from 9 medical centers in the U.S. Totally, they have 90 adult patients selected and divided into the mechanical ventilation with VA ECMO and the conventional mechanical ventilation. There are 4 patients survived in each group. The conclusion from this study is ECMO can support the respiratory gas exchange but did not increase the probability of survival. This is maybe because at that time they put the outdated device, is an old version ECMO device, and every patient got the VA ECMO rather than VV ECMO like we're using right now. And all the patients put in the ECMO after prolonged the mechanical ventilation, which is can destroy the lung a lot before the patient on the ECMO. And at that time, they put profound anticoagulation, so the complication of the bleeding a lot at that time. This is a landmark study, another landmark study performed to answer the question regarding the benefit of the ECMO in the ARDS. Is run in the UK during 2001 until 2006. This study selected the adult patient who have the ARDS potential, reversible ARDS with a Merlin score equal to 3 or more than 3. And uncompensated hypercapnia. And they look at the death and severe disability at 6 months and exclude all the patients that should not be on ECMO, like a patient that have intracranial bleeding and have the contraindication for the ECMO. So totally, they have 180 patients and divide it into 2 arms, 90 in each arm. The primary result showing that there was a benefit of the ECMO in the ECMO group have the primary outcome better than the conventional management group. And the patient died from respiratory failure in the ECMO group lesser than the conventional management group. So this trial conclude that the patient who transferred to the ECMO center got a better outcome than those treated with the original hospital with the conventional therapy. And also, is this cost effective? However, this study was criticized for in the ECMO arm, the patient, not all the patients got the ECMO treatment. Only 68 patients got the ECMO support because of about 16 patients improved with the conventional management. So at least 22 patients do not get the ECMO. So we cannot use the result outcome on the ECMO arm 100%. And another thing is in the control group got the low volume and low pressure ventilation strategy only 70%. There was no similar strategy to manage the lung condition. So they have another big randomized control trial to compare between the patient with the ECMO and without the ECMO on the ARDS. This is the EORIA trial. It was run in 64 centers international, but mostly in France. Just published in New England Journal in 2018. This study including the 249 patients, and randomized into the ECMO group and the conventional group, 124 and 125 in each group. And the result was the primary endpoint. There was no statistic significant between ECMO group and control group. However, in the ECMO group, got a better result in terms of a secondary outcome because of the treatment failure at 60 days after the treatment, better than the control group. And the median free from the renal replacement therapy in the ECMO group is lesser than the control group. And in the ECMO group, the patient got the prone position lesser than the control group. Because there are some group of the patient that need, in the control group, that need the treatment by the ECMO. Around 35 patients need to treat by the ECMO. So there were a group of patients that crossed over from the control group to the ECMO group. The median time to cross over is around 4 days, and the median PF ratio is around 51. Median SAT is 77, and lactate is 3.2. In this group, the patient looked more severe than the average control group because 9 patients had the cardiac arrest, 7 patients had the right heart failure, 11 patients need the RRT, renal replacement therapy, and 6 patients need the ECPR. So the mortality rate in the crossover group is higher than the average control group. So in the EORIA trial, they conclude that it's not, they cannot inconclusive support for the benefit of the ECMO. However, it looks like the result of the EORIA support that if the patient got the ECMO earlier, gonna be better result than the patient who got the very late ECMO. The weakness of this trial is because the study stopped earlier because there was they have a too high estimate mortality in control group and a high crossover rate in control, which is dilute the ECMO treatment effect and slow recruitment and expertise of the ECMO center not clearly defined. And do not distinguish between the use of the VV and VA in this study because there was some patients need the VA ECMO. During 2009, there are a pandemic outbreak of the H1N1. There are many patients need the ECMO at that time. So the role of the ECMO in the viral pneumonia exhibit from that time. This is I picked up one study from friends at that time. They totally picked up from the patient around 1,700 patients and match the condition. So totally, they have 75 match pair between GenMat matching. In the GenMat matching, they found that the group of the patient who refer to the ECMO center get a better result than the patient that do not refer to the ECMO center, 23.7 versus 52.5%. And recently, pandemic of the coronavirus. This is a recommendation from the WHO. This is backed up by the EORIA study. the WHO recommend that the center who expertise in the ECLS consider referral patient with the refractory hypoxemia despite the lung protective ventilation. And this is data from the Chinese medical center that report the 41 case of coronavirus. There was around 5% of the patient that need the ECMO. Also the trauma, as I mentioned, the first case was the trauma. I'm gonna skip this. And also the ECMO also have a role in the lung transplant because in some patients, especially in the patient that list on the lung transplant and need intubation. This is criteria to using the ECMO to bridge to lung transplantation. And also during the transplantation, the ECMO can stabilize the hemodynamic and prevent the first lung syndrome after the transplantation. And after the lung transplantation, in some cases, which is have a early primary graft dysfunction, the ECMO can help this patient. Also, the massive pulmonary embolism. This is a study from the Dr. Barrett group. Around 21 patients that treated by ECMO, 19 patients on the VA and 2 patients on the VV. And in 10 from 13 patients who survive, the ECMO can by the time to give the anticoagulation and the emboli resolve by itself, do not need the open heart surgery to do the pulmonary embolectomy. And so what was 62%. So this is an indication for the non-cardiac ECMO. This is published by the ELSO. The most common indication is the hypoxic respiratory failure, especially in the group that patients have the mortality risk more than 80%, such as PF ratio lesser than 100 and Murray score 3 to 4, and CO2 retention and the air risk syndrome, and the patient who on the lung transplant list and need intubation. This is result from our center. As we can expect that most of the patients have a criteria from the severe pneumonia with the ARDS. And this is our result during past 5 years. On average, we can run the serval to the discharge from the VV around 62%. So right now, the published from the ECLS literature of the ELSO tell us that the average serval of the non-cardiac ECMO is around 60%. So in conclusion, ECMO is the treatment of choice for the patient with the respiratory failure, refractory to optimal mechanical ventilation and conventional medical treatments. However, there is a complication, significant complication that we should consider before putting ECMO on. And appropriate patient selection is critical for successful ECMO outcome. Thank you. Okay, for the next topic, is LVAD as a rescue for cardiogenic shock patient and update. This is going to be the video again.
Dear friends and colleagues, it is my pleasure to be speaking to you today. I would like to thank the ASCVTS and to VSAC for the kind invitation. My topic today is mechanical circulatory support as rescue for cardiogenic shock patients, an update. I'll be talking about some of our protocols at Cleveland Clinic and some of our approaches that we have in dealing with these patients in acute cardiogenic shock. I'll speak about the indications of mechanical circulatory support in cardiogenic shock, as well as some of the options that we have for temporary assist devices. Let's start with a clinical case. We have a 55-year-old male with acute chest pain and shortness of breath for 48 hours and presents with a STEMI in the anterior leads. On the left heart cath, he was found to be RCA dominant, which has a severe diffuse disease. The LAD has a total occlusion after D1, and the circumflex has mild disease. From his coronary angiogram, you can show that the RCA is severely diseased and the disease is quite diffuse. And on his left side, you can see that the LAD is completely occluded. He then undergoes a PCI to the LAD with a good result with a TIMI2 flow and a balloon pump was inserted. These are the post-procedural pictures with a good flow down into the LAD. However, the patient remains in cardiogenic shock. His MAPs are 60, CVP is 18, wedge is 24, and the cardiac index is only 1.4. He was then transferred to Cleveland Clinic, where he continued to have VTs. His urine output was low. He was acidotic with a pH of 7.2 and his lactate was elevated. On echo, his EF was around 10%, the RV was moderate, and he has mild mitral regurgitation. At 2 o'clock in the morning, the shock team was activated upon arrival to Cleveland Clinic. We know from the shock trial that despite early revascularization, patients with acute myocardial infarction with cardiogenic shock have a very high early mortality, around 50%. And this is because although the coronaries are successfully revascularized, the recovery of the myocardial performance following revascularization may take days, and patients can succumb to the low cardiac output while the myocardium is recovering. Therefore, if cardiac support could be provided while awaiting for the beneficial effects of revascularization to take place, then survival rates may be improved. The goal of early mechanical circulatory support in these patients are as followed. We want to normalize and stabilize the patient's hemodynamics. We want to normalize the end organ perfusion. We want to set the patient up for potential cardiac recovery and weaning. And also, in patients whose cardiac function will not recover, we want to buy time for the patient to safely transition to an alternative strategy, such as an LVAD or transplantation. The devices that we have at Cleveland Clinic are as followed. Our preferential devices are the three following: ECMO, Impella, or a CentroMag device. In terms of the degree of support, the balloon pump also can be used in these situations. However, the intra-aortic balloon pump only gives the patient about 0.5 liters of incremental cardiac output. The Impella CP, which is a percutaneous device, is able to deliver about 3.5 liters of flow, whereas the CentroMag and Impella 5.0 can deliver full flow around 5 liters. And finally, ECMO can also deliver 5 liters of flow, with the advantage of also providing pulmonary support with oxygenation to the blood if necessary. In terms of the ease of insertion, the easiest to insert is the balloon pump because it is totally percutaneous. The Impella CP is also percutaneous but requires fluoroscopy. Moving up the chains, Impella 5 and Impella 5.5 requires an axillary cut down. And finally, central ECMO or CentroMag all require a sternotomy for insertion. However, the ECMO in a peripheral cannulation strategy can also be placed in a percutaneous fashion. In our patient who presents with a cardiogenic shock following the PCI, we place the patient on ECMO. The advantage of ECMO in this setting is the fact that it is rapid response and it's easy to initiate. It can be applied at the bedside without imaging, and it provides biventricular support. However, on the con side, it can lead to limb ischemia and hypoperfusion of the leg and hyperperfusion of the arm when it's placed in the axillary fashion. It can lead to LV distension. It can limit recovery. It can lead to pulmonary hemorrhage and poor coronary perfusion. In cases where ECMO is used when there is severe LV dysfunction, it can lead to aortic thrombus formation. And it can also cause Harlequin syndrome when placed in the peripheral cannulation strategy, as the oxygenated blood may not reach all the way up to the brain and to the coronaries. You're also not able to decouple the left and right ventricle, and therefore it's hard to assess the function of the right ventricle when somebody is on ECMO for you to decide whether or not they're an LVAD candidate. To mitigate some of these risks, we now routinely do place a reperfusion cannula. In this picture, it's used a 6 French sheath, but now currently we always use an 8 French sheath, which is placed in an antegrade fashion to provide blood flow down in the distal leg. And since we've done that, we have had very few episodes of limb ischemia. In our patient post-ECMO, however, there was no pulsatility without the balloon pump. Patient required a large amount of fluids, and the echo post-ECMO showed severe biventricular failure with a distended LV and RV, and the aortic valve is not opening. Within 24 hours following ECMO, this is what happened to the chest x-ray. As you can see, patient developed severe pulmonary edema and the x-rays became whited out. Now let's look at what's happening on a physiologic level inside the left ventricle. I have the pressure volume loops of a normal heart. On this patient, you can see that the cardiac output is about 6 liters a minute with a normal blood pressure. In a patient with acute heart failure, however, the pressure volume loops will shift to the right and the total ejection fraction will decrease. The blood pressure will also drop, and also with that, the cardiac output would also decrease. With the patient with a low blood pressure, the first response may be to start the patient on an inotropic and pressor support. So we can simulate this with the software that Dan Burkhoff developed called Harvey. We can put the patient on 8 of norepinephrine and the 0.2 of epinephrine, and we have an immediate response in blood pressure with the MAPS now improving to 80. However, the cardiac output dropped even further, and we've shifted the curve further to the right. This leads to a further increase in LVAD, which then places additional pressure and additional volume and overload onto the lungs. And we also know that with escalating doses of inotropes and pressor support, the mortality associated with these patients increases exponentially. The patient then enters a spiral where you have a low MAPS, which then leads to organ malperfusion, which then further causes further acidosis on the heart itself, which then further leads to lower MAPS, and you have a death spiral of cardiogenic shock. With mechanical circulatory support, the goal is to try to reverse this trend. The first device that we can try is an intra-aortic balloon pump, and we can simulate the effects of the intra-aortic balloon pump with the software. With the intra-aortic balloon pump, we are starting to shift the curve back to the left. However, the effects are just too small. There's a marginal increase in cardiac output and a marginal decrease in LVAD. However, this is not sufficient for this patient. And because of this, we know that from a SHOCK 2 results that the intra-aortic balloon pump really did not make any difference in mortality in patients in cardiogenic shock. Next, we can look at what happens in a patient on ECMO. With the ECMO, the curve shifts further to the right because of the high afterload. Although the MAPS improve significantly and the body is well perfused, the heart really is at a standstill and with very little ejection. So in patients who already have a poor ventricular function, placing these patients on ECMO will ensure that there is complete stasis inside the ventricle and with a high potential of clot formation. The LVAD also rises, and this is what really leads to the fact that we have a pulmonary edema on patients like this. Over the last couple of years, we've really adopted the strategy of LV unloading when we have patients who have poor ventricular function on ECMO. And this is best done with an Impella device, which we can either place in the femoral with a CP, or what we prefer to do is place a 5.0 in the axillary. With the LV that's unloaded, there is decreased tension on the myocardium, and with that, there's increased myocardial perfusion. And there's also animal studies which show that with unloading, you decrease the size of the infarct in the setting of acute myocardial infarction. We place a 10 millimeter graft on the axillary artery and a 5.0 Impella, and now we have a 5.5 Impella is inserted through this graft into the ascending aorta across the aortic valve. We can also simulate to see what's going on inside the myocardium when we have a patient on the Impella. So by turning the Impella on, we are immediately able to shift the curve to the left, and with that we can also take the patient off of ECMO and take the patient off of their pharmaceutical support. And with this, you can see that the LVEDP has now decreased from 33 down to 19, and the maps remain robust. Typically about 24 to 40 hours after Impella insertion, the pulmonary edema will start to resolve. And on echo, you can see that the distended left ventricle is now back to in a more appropriate size with a nice balance of flow between the left and the right. So with the Impella of the last few years, it has really allowed us to change our whole approach and change our whole paradigm in a patient who's on ECMO. So when you have an unstable patient, ECMO may still be the first treatment of choice because it is the most readily available and easiest device to insert. However, when you recognize that that patient has LV distension following ECMO because of the high afterload, this will immediately lead to pulmonary edema, potential for LV thrombus, and poor myocardial recovery. You're supporting the body at the detriment of the heart. Previously, the strategies to combat the LV distension is to keep the patients on inotropic support. Of course, we would start the patient on anticoagulation and perhaps even use a balloon pump. When this is insufficient, we consider doing apical cannulation as well as possibly putting an LV vent or a septostomy. However, now with the Impella, we can replace all of this with a single step and a single device. And this has overall changed our strategy and changed our approach with these patients. So back to our patient. Patient received an Impella after the ECMO insertion. Patient was successfully decannulated on post-op day 5. He was discharged from hospital on post-op day 22, and the ejection fraction eventually improved from 15% up to about 40%. Now, how do we choose which device and when do we place these devices? In patients who have a closed chest, if the patient is stable enough to go to the operating room, in that situation, we would prefer to bring the cardiogenic shock patient to the operating room and place a surgically implanted Impella 5.0 or 5.5 immediately in the operating room in an axillary fashion. If the patient is unstable to transfer, we will put the patient on ECMO. However, we will not leave the patient on ECMO. We will then escalate to an Impella and have the patient on both ECMO and Impella or ECPella. If the patient already has an open chest, and this is something you've already anticipated, an axillary Impella can still be inserted, and this is still our treatment of choice. If the cardiogenic shock was unanticipated and you do not have the time to do an axillary cut down, there is an Impella LD device that can be inserted directly in the ascending aorta without fluoroscopy, and that can also deliver 5 liters of flow. Or we can also put the patient on a centromag device to wean the patient off of a cardiopulmonary bypass and to allow them to recover from the shock. There are times, however, where in left ventricular device alone is not enough, and the right ventricle is also severely dysfunctional, and we also need right ventricular support. There are many different parameters that we can look at for right ventricular function. On echo, we can look at the visual right ventricle function, how dilated the RV is, as well as the TAPSE. On hemodynamics, we can look at the CVP, we can look at the right atrial wedge ratio, RV stroke work index. However, the indicator that seems to be the best is something called PAPI, which is PA pulsatility index. And you calculate that by calculating the PA pulsatility, so pulmonary artery systolic minus diastolic, and you divide that by CVP. And if the ratio is less than 1.5, then typically you have a patient whose right heart is struggling in that case. Having said that, most patients who are going into the operating room or you are planning to place a device who already has biventricular failure, most of the times, once you support the left side and decompress the left side, the right side is able to recover without any additional mechanical support. However, if you have persistently high CVP and low cardiac index despite a fully unloaded left side, or if you have a situation where you cannot titrate up the flows on the left side without causing a severe shift in the ventricular septum to the left, then these are situations where you do need to put a right ventricular device. The two devices that we have are the Protect Duo or the Impella RP. The Protect Duo is placed in the internal jugular and it is floated into the pulmonary artery, and the Impella RP is inserted into the femoral. Alternatively, if this is a patient who already has an open chest, we will sew a graft, a 8mm graft onto the pulmonary artery itself and bring this graft out from the patient's skin and put a percutaneous femoral venous cannula. This system can then be attached to an ECMO circuit, which then allow us to be used as an RVAD. Once the patient chest can then be closed, once a patient is ready to be weaned, this device can then be removed at the bedside in the ICU. So in 2020, our paradigm for patient and cardiogenic shock is as followed. If you have a patient who has cardiopulmonary collapse, a shock team is activated. If a patient is stable, we'll go to the OR. If the patient is unstable, we'll put the patient on VA ECMO at the bedside. We'll always put a reperfusion sheath. But from there, we will try to get the patient off of ECMO and onto an alternate strategy. We will start with an Impella that's inserted. Following that, if the patient has isolated left ventricular failure only, we will get the ECMO off and leave the patient on an Impella only. If the patient has biventricular failure, we will put a temporary RV device and get the patient off ECMO. If the patient has respiratory failure, then we will remove the VA ECMO and transition to VV ECMO with the Impella. If you look at overall how our practice has evolved, prior to 2010, in patients who were in shock, we would maximize their inotropic support and consider MCS only as a last resort. In those settings, the patient will have a long hospital stay and poor outcomes. However, in the more recent years, we've used mechanical circulatory support at a much earlier time and a much earlier progression in the patient's hospital stay. And with that, we have experienced a much shorter hospital stay and avoided the incidence of multi-organ failure with the overall better outcomes. Thank you very much.
The next topic is management of breathing complication during ECMO. Going to present by Dr. Piya Samankatiwat.
Thank you, Mr. Chairman, and good afternoon, ladies and gentlemen. It's my great pleasure to be here. My topic is about breathing management on the ECMO. However, it might not be something new for you, but I try to review a lot of papers on the management of the breathing complication. And so what I'm going to talk this afternoon is about the problem of the hemorrhagic complication during the ECMO that all of us might have encountered before because of the it's quite a common and major complications of the ECMO, and so how to deal with it, and also the conclusion. So this is the diagram of the ECMO that we mostly use the VA ECMO that we commonly use it for the support of our patients, and we are very familiar with the system. However, you can see that the ECMO carries a lot of complications. There was a review, a meta-analysis of the complications and mortality of the ECMO. Hemorrhagic complications of the ECMO comprises about 40% of all complications that we face during we run the ECMO. And one of the most common site is the GI bleeding. That's very quite our headache to do or to deal with these complications. And if we look at the bleeding complications of the ECMO, because of the ECMO itself is the major risk factor of the bleeding, because it has the anticoagulation. The patient is in the critically ill status, and also inflammatory response of the body, and also there is consumption of the platelets and coagulation factors. In terms of the predictive factors of bleeding in the ECMO, from this study published in 2016, they conclude that the predictive factors of the ECMO during the patients on the ECMO is the higher APTT. If the APTT is quite high, it has the odds ratio higher than the lower APTT level. Aperture 3 score also affect the complications. And ECMO itself, the ECMO following surgery contain a high risk of bleeding complication. So how can we deal with this problem? Within my talk is in 15 minutes, I try to cover the whole thing that we have to do. Firstly, we have to identify the point of bleeding, evaluation the bleeding pattern, and also determine the cause of the bleeding. Common site of bleeding during the ECMO. This paper is published in last year, quite recent. We can see that the most common site of bleeding point is in the surgical site bleeding. So if we put the patient on ECMO after the operation, this is the high risk of bleeding that we can imagine by logic thinking. Another one is the cannulation site bleeding, pulmonary hemorrhage, gastrointestinal bleeding, and also intracranial hemorrhage. So I can summarize the problem like in this slide. The first of all is the surgical site bleeding, ECMO circuit related, that is the cannulation site, and also the end organ bleeding. The three major sites of bleeding is the intracranial, pulmonary hemorrhage, and also the gastrointestinal or GI bleeding. Surgical site bleeding is about 6 to 32% of all bleeding in ECLS. The major majority is at the post-operative cardiac surgery. We have to give the patient heparin for our operation, and then they bleed afterwards, especially on the ECMO. So sometimes we have to return the patient back to the operating theater to in order to control the site of bleeding if it's necessary. Local hemostasis agent can help a little bit, and also after the controlling of the bleeding, we have to reverse the heparinization and suspend the heparin for the ECMO quite a while. And then I will tell you later about the management. Concerning the cannulation site bleeding, it depends on the type of cannulation. In central cannulation, we cannulate the aorta and also, as well as the right atrium, that we have to do our best on the local control of the cannulation site. Must be highly skilled. However, on the other hand, the peripheral cannulation is quite easier to do. However, the Selinger technique is better than the cut down or semi-open technique. And so we have to do our best to locally control the bleeding point at the cannulation site. Otherwise, it's quite like a nightmare for the personnel or our team to do the post-cannulation bleeding. In terms of the in-organ bleeding, as I said, that about 3 major sites of in-organs that have, the majority of hemorrhage. The intracranial bleeding is about 3 to 6% of bleeding point in ECMO, and it is the most devastating problem. The pulmonary hemorrhage, we don't actually know at the moment concerning its mechanism of the problem. However, in theory, it would be the vasculitis during the ECMO that happened after after the ECMO initiation quite a while. And also the same, should be the same mechanism at the GI hemorrhage. So what we can do, first of all, we have to evaluate the bleeding by concerning the hemostatic evaluation first, if the platelets is adequate in numbers and also its function, anticoagulation functions is okay or not, or the fibrinolytic activities. The test that we normally do is the ACT, APTT, and complete blood count, and also the LOTEM. At the moment, there are many reviews advocating LOTEM to predict or to evaluate the cascade or the coagulation function, that which one is abnormal or which one we have to collect first. And also we have to evaluate the pattern of bleeding point, the type. Is it arterial bleed, venous, or capillary? Because the arterial bleed and venous bleed, sometimes we have to return the patient to the operating theater for correction or for controlling the bleeding point. And for the capillary bleeding, it's usually comes from the coagulation problem itself, not the surgical one. And sometimes we have to evaluate point of bleeding by the bronchoscopy, endoscopy, upper GI and lower GI evaluation, and also imaging can help. This is the steps of the agents that we can use to treat the bleeding in ECMO. This paper is also published last year. They think like a pyramid from the base to the tip of the pyramid. That the topical agent itself can help at the local site of bleeding, such as you can use the topical thrombin, Surgicells, or topical antifibrinolysis agent. There are examples of the agent that we can use. And the next step would be the number of and function of the platelets and the fibrin. We have to test to look at the fibrinogen level and also the platelet concentration. We have, in the next step, we think about the antifibrinolysis, systemic antifibrinolysis agent, such as the tranexaminic acid. In the past, some people might think about aprocitentan. And the top of the pyramid is the von Willebrand factors and also the recombinant factor 7. This is the algorithm proposed by this group, published in 2013. I'm so sorry about the small alphabets and small figures. However, they just think quite straightforward. Firstly, if we have a severe breathing problem in the ECMO, they think about conventional treatment first, including surgical site, as I mentioned, the blood component replacement, and also the hemostasis agent, hemostatic correction. And then they will consider the recombinant factor 7, even it contains or carries some thromboembolic complication risk. This arm, they put the patient on the recombinant activated factor 7. They consider this, and also the pharmacological method to reduce bleeding. And this arm, they optimize the hemostatic function, such as they correct acidosis, correct hypothermia, and also replace calcium to the patient. And think about the maximization of the platelet numbers. Fibrinogen level should higher than 1, and also hematocrit higher than 24%. And correct the pH. That is the goal-directed therapy of the hemostatic optimization. And then they will consider if the bleeding still keep going on, they will consider the recombinant activated factor 7 for the correction of the bleeding. So control of the bleeding, in summary, is about the local control, optimization of the metabolic disturbance, and correction of platelets and coagulation factors. Local control, some surgical bleeding, we have to bring the patient back to the operating theater to do the local control of the bleeding point. We can use the local hemostasis agent, and after the control of the bleeding point, even if you feel comfortable to control or comfortable with the result, you can sometimes you have to keep the lower ACT for a couple of hours to let the hemostatic function completely do their job, and you have to prepare another ECMO circuit to circuit replacement if we have the composites of the oxygenator. That is the most important one, important backup that we have to do. To optimize the metabolic disturbance, that is, we have to collect acidosis, normalize pH, replace the calcium, and correct hypothermia. That I mean, keep the patient warm back to normal thermia. Correct the platelets and anticoagulation factors. Replace the blood cell for hematocrit to keep it higher than 24. Keep the platelets higher than 100,000 cells per millimeter of cubic millimeter, and fibrinogen level higher than 1. And pharmacology that we can use is the tranexaminic acid, recombinant factor 7, and also von Willebrand concentrate. Okay. So in conclusion, ladies and gentlemen, hemorrhagic complication during ECMO is one of the most devastating, and it is one of the most common complications that we have to deal with or to manage. Surgical site bleeding after cardiac surgery is very common, and so you have to return the patient back to the operating room for local control, and also identification of bleeding pattern is very important in guiding appropriate management, and also the correction of metabolic derangement as well as the hemostatic function is generally important. And as the last resort, recombinant activated factor 7 can be used. However, it has a risk of thrombosis complication. Thank you very much.
Thank you, Dr. Pia. This is a last topic, so now we're gonna step to the question and answer session. Let me have a first question to Dr. Peterson. According to Dr. Tong talk in his video, he mentioned that in your center you have Impella and IABP. If you have a low EF CABG, after the operation, the patient developed the low cardiac output, how would you select between the Impella and IABP? As we know from the shock trial that the evidence that support the IVP is less and less over the time, but we do not have the post-operative study regarding the role of the IVP. So how would you select between the IVP and Impella?
Is it on? Yeah, so this has really changed over time how we approach these patients. And of course, one of the driving factors is also actually the quality control of the STS, and so that so to say has been an incentive for us to decide beforehand what we want to do and to work these patients up and have them consented for support devices beforehand. I think that has been a very good thing. And it's no question that Impella is very much more effective than intra-aortic balloon pump. Intra-aortic balloon pump actually has a pretty marginal effect. And you saw from this ECMO case that he had on the second video here, and I think we've been aware of that for years, that ECMO is a problem when you put afterload on the LV and you actually don't get any recovery, and it's very hard when you run an ECMO in the intensive care unit to maintain pulsatility, and it really requires a very careful monitoring if you want to get the myocardial recovery with ECMO. So I would say that Impella is really our first choice, and patients are most often nowadays consented for that. I initially felt that the young guys were a little bit too aggressive with wanted to use that, but it is no question that it works very well, that this strategy of if you have a marginal cardiac output, then be prepared to put in an Impella and don't hesitate. As of course it's not a cheap therapy, so if you put it in and it really wasn't needed, of course you wasted some money. But I still think it's so safe that from a patient safety and survival standpoint, you have really done minimal harm. Of course, it's never totally without risk to put in devices and so into the patients, but it works surprisingly well.
It's quite hard for us because in Thailand we do not have an Impella as an option right now. So we have to always start with the IVP. Then if we cannot control, then step up to the ECMO after that.
Can I make
yes.
one comment to that? I think in the ECMO situation, and you talked about that for respiratory failure, and so of course you really have to make sure that you have transpulmonary flow, and you can have a combination of VA and VV ECMO to maintain cardiac output. So you're not bypassing the heart continuously. That's not good for the lungs. It's not good for the heart. So we have become more sophisticated in the way we cannulate to always make sure that we have transpulmonary flow and that we don't so to say over distend the left ventricle. And so we're really very aware of this and this Harlequin phenomenon that when you have a too good heart and non-functioning lung, that you are killing the heart and the brain by not giving them non-oxygenated blood.
Yeah, sometimes we need to add another venous cannula, so it's gonna be the VAV system. All right, and for regarding the breathing in the ECMO, I would like to ask Dr. Pia, how far should we go for the case that got the breathing after VA ECMO? In my experience, I never stopped the heparin longer than 2 hours. 2 hours is maximum that I dare to stop it. Any other option? If we stop the heparin, collect the factors, and it's still breathing.
Yes. Okay. Thank you very much. It's a good question and quite difficult to answer because of sometimes we face that problem because after mainly I think you mentioned about the post-operative ECMO or the kind of cannulation.
Oh, just the general VA ECMO
Yes.
that we cannulate through the groin.
Okay.
Sometimes we got the medical breathing
I see,
in the
yeah.
tube in the cannula
Okay.
side that we could not fix the thing with the surgical technique.
Yeah, thank you. Yes. Okay, that is the most or very common problem that we have to manage. My experience, we also have the same problem. For even we put the patient on the peripheral cannulation. If the bleeding point is at the cannulation site, it's normal after quite a while. It depends on your technique. If you use the syringe, you should not, at the time of cannulation, you should not dilate the skin and soft tissue too much. We dilate one number below the number of the cannula. Normally the cannula comes with odd number, but the dilator comes with even number. So for the 21 French ECMO cannula, I dilate just for 20. I don't over dilate. That's the first technique. However, if we already over dilate and it bleed, or if we put the patient quite a while for a couple days and the dilatation, the cannulation site become loose and bleed along with the cannula, it's really, really difficult for me as well. But we cannot put anything. Just what we can do is just open the cannulation site up and tie the vessel more. That's what we can do. Or otherwise, we have to change the cannulation site. That is the problem of the cannulation. And the end organ bleeding, as you mentioned, like intracranial. I have one experience on a patient that after 2 or 3 days after VV ECMO for ARDS, and the patient developed intracranial hemorrhage. We stopped heparin, or we lower the heparin to control the ACT as low as 150 to 160 seconds for couple hours, and bring the patient back to the theater, do the craniotomy, remove the clot because it's more likely the herniation. So we stop the heparin afterwards. And I have some experience on stopping the heparin for 24 hours because we believe that the circuit has been already heparin coated, so it can delay heparinization for at least 24 hours. And but you need to have the backup oxygenator and new circuit backup. If we see the oxygenator clog, just change it, and that's what my experience.
Yeah.
Yep.
In our experience, it's easy for the VV ECMO because we can run the high flow and stop the heparin for a long time. The longest time that we stop is around 4 or 5 days without any problem for
Exactly.
the VV, but the VA is more difficult for us.
Yeah, I have one experience, at least about the VA ECMO after pediatric cardiac surgery. I do the complex procedure. I cannot remember the case. However, remember just about the ECMO because we have to delay sternal closure, and the patient got bleeded from the raw surfaces, and I have to stop the heparin for 24 hours. And finally, the bleeding stopped after correction of all anticoagulation factors and platelets. And but that case, I did not give him recombinant factor 7 because I am afraid of the thrombosis. Finally, after 24 hours passed and the bleeding stopped, the oxygenator clotted, and I replaced the circuit, and that is successful.
Yes, I would like to ask Dr. Patterson here. In the talk of Dr. Tong regarding the low EF CAD with low EF, he didn't talk much on the patient with a low EF with a low gradient aortic stenosis, and with the CAD, good targets, but the LVs, the contractile reserve is very poor. How would you strategize this? What's the best support preoperatively? Is a balloon is enough to support this before going into doing the AVR and plus the CABG or an Impella, I think, can it be? How would you use an Impella with the aortic stenosis? Yeah.
Yeah, we almost never put in any support beforehand. You know, it's if we are presented with a patient on support, that's already there by the cardiologist before we even asked about it. You know, we would go to the operating room and then deal with the kind of support afterwards. Of course, you can't use an Impella with a mechanical valve, so that choice becomes easy. And if you have a low EF and we'll say a low gradient aortic stenosis, it's of course the difficulty is also to evaluate the severity of a stenosis. Is this aortic stenosis significant or not? If we are in to see this patient beforehand, right heart catheterization is something that we would do on the vast majority of these cases to see what kind of cardiac output, cardiac index do they have, and do we really think that aortic stenosis is significant? It would be very unlikely that the patient you would have, that you talk about, has really aortic stenosis, so you couldn't pass the valve with an Impella if you wanted to. But if in any doubt when we go to the operating room, we would replace it. If you look at many of these patients that Dr. Tong is talking about, you know, we didn't hesitate to operate on those patients for a couple of years ago, and we didn't think that they were that very high risk. But you know, the thinking today about the risk is a little bit, it's a little bit difficult, a little bit different, and it's no question that the recovery and the hospital stay for these patients is much more favorable when you never allow them to have low cardiac index and organ dysfunction and renal problems and so afterwards. All of that you prevent by giving them this kind of organ support for a couple of days. And it seems like just a few days is enough. It's been very unusual in our experience that the patient gets hooked up on it, and we need to keep it for an extended period of time, a week or more. That's very unusual. But we overuse it, I'm sure.
Sometimes we encounter patients AVR with CAD, very bad LV, and we cannot. There's difficulty in weaning the patient from cardiopulmonary bypass, and the only alternative that we could do is put them on ECMO. Yeah.
And that we know that that's not really a good strategy. But I think the key point here is that the STS thinking and the thinking and protecting, but we don't want to have isolated cabbage mortalities. That's a catastrophe for the reporting, see, and our star ranking and all that. But the good thing is that it forces us to think about this beforehand. That's the key.
Chris, right there. There's a microphone in the back.
Hi, with regards to the bleeding, say post-cardiotomy and you decide to put the patient on ECMO, would it make sense to shift, say you already have your cannula, so shift it peripherally to decrease the amount of surface area of bleeding, or do you just leave the cannulas there? Because in our one very limited experience, we had some patients who had bleeding issues and eventually didn't do well, whereas another patient, we shifted to a peripheral cannulation, was able to close the chest, and the patient did well. But, we really couldn't say whether that strategy was really the main cause of patient improving.
I agree with you. Yes, I agree with you concerning the shift the site of cannulation to the peripheral one. But you have to think about that. To change to the peripheral cannulation, you will create another problem, mainly the limb ischemia. But my major concern, and also it depends on how large wall surfaces that you have at the operating site. To me, if it is a redo cases, it's a lot of wall surfaces that you have to lysis the adhesion. Yes, that I agree with you. If we can shift, but very careful to give the distal limb perfusion cannulation. Otherwise, the patient will lose the limb as well. And however, comparing between the cannulation, central cannulation and the peripheral one, I prefer the central because it's, less in terms of the less problem of the limb ischemia, and also it provides good good ECMO flow rather than the peripheral one. But it depends on if you don't have anything to go back in, and you and you do everything perfectly. But just for the ECMO, I think I agree with you to put the peripheral cannulation rather than the central one. Yeah. But don't overdilate the site, the skin, and the soft tissue. Yeah.
What about the reperfusion cannula? We talked about
limb ischemia, yes. The distal perfusion cannula. I put the 8 to 10 French catheter. Yeah. Also.
You still have it? You're still afraid of it?
Not quite, but sometimes it doesn't work. Yeah. So we have to, do it very carefully. But my practice, I'm a pediatric cardiac surgeon. No, so mainly my preference is to do the central one because, yeah. However, I have some central cannulation on the large, adult patients or the big pediatric cases that I don't have any problem with the central cannulation, but the immobilization of the cannula is very important. to prevent the dislodgement of the cannula and also the moving of the cannula. Yeah, and we close the chest normally in the ICU. Yeah, I have one experience on the 12 years old child, a boy, who comes with the myocardial failure, myocarditis, and we put the patient first on the ECMO, and then what happened is the same as the previous presentation, that they get white lung. I bring the patient back to the operating room to do the LVAD as the LV decompression all together with the ECMO, and keep the patient to relieve from the pulmonary edema, and then shift the ECMO, decannulate the ECMO and put the right VAD, RVAD. And finally, the patient get heart transplanted and survive. Yeah. So that is my experience. But because the ECMO cannulation site is also, peripheral cannulation, but a week later, it bleed at the site. Even I dilate. I did not over dilate, but the cannulation site became loose, and the bleeding is along the track of the cannula. That's happened, and that force us to bring the patient back to the operating room to put the RVAD. Yeah.
One more question.
Yes.
When you say reverse your, let's say, heparinization, you mean to withdraw the heparin, right?
Yes.
Not administer anything, protamine or anything.
Okay.
And how much, is there a guideline? How long do you withdraw the heparin?
Okay.
Yeah.
Okay. It depends on the time of bleeding. If I face the bleeding at the operating room, at the end of the operation, I will fully reverse heparinization with the protamine to bring the ACT as normal. Yes, normalize ACT. Put the patient on ECMO without heparin. Yes. Yeah. Until we are very sure that the bleeding stopped. Yeah. But if we find the bleeding problem at the ICU, and we do nothing with the, we will do nothing with the operating site, I will just reduce the heparin to bring the ACT below 160. Keep it between 150 and 160. Yeah, and for a couple hours or even longer. It depends on the correction. Otherwise, you cannot correct the anticoagulation. Yeah. Yes, please.
Thank you, Dr. Pia, for a really useful topic. So I think bleeding complication has a very important issue, and as well as the clotting complication as well. I used to have a case who came with the dengue fever with the DIC, and at the first time before we do the cannulation, the ACT is prolonged already,
yes.
And our surgeon give the heparin before cannulation, but after that they let it drop down and don't give
reverse,
it anymore.
Yeah.
But ACT is still prolonged. After that, around 6 hours, we got the membrane clot. So I would like to ask you and our expert here that all of you used to have the experience with maybe some situation with DIC and how to prepare before putting the patient on ECMO or maybe during the way that we take care of the patient.
Yeah,
Thank you.
It's quite difficult question to answer because this is the real world that we have to face, and I have some experience on that as well. Because of the mechanism of hemostasis in terms of the platelets and the coagulation, they are different. They are on the different arm of cascade. To the prolonged ACT is like the summation of prolonged hemostasis. So we have to use something more, more precise to evaluate the clotting mechanism. For example, like a DLOTEM, to look at in every level of the coagulation, and we collect direct at the problem. Yeah. So it depends. To me, we also have the same situation like you mentioned about the dengue hemorrhagic fever with ARDS, and we have to put the patient on the ECMO, especially on the VA ECMO, because we at that time the patient is in the critically ill situation, low cardiac output with high SVR and low blood pressure, and we have to put the VA ECMO. The patient has a very low platelet count. We replace a lot of platelet. We replace a lot of coagulation factors, and also we do the filtration that can help. I think because of the activation of the complement system and also cytokines may lead breathing problem as well because of the inflammation. And so we do everything, and finally we get the oxygenator clotted as well. And so we have to change, but we have to prevent the clot in cannulation. That's it. Otherwise, it will be a nightmare, completely nightmare. Yeah.
I think the problem we fear is not the membrane clot, but we fear a lot on the cerebral emboli. Yeah, especially we put the VA ECMO on the peripheral. It is a lethal gate flow. If we stop the heparin for a long time, then it may causing the cerebral emboli. So we have to balance between the bleeding risk and the thromboemboli. But luckily, in our experience, we just stop for 2 hours, then the breathing stop, and we can start the heparin and flow the ECMO again. The changing the membrane, we also have the problem that when we stop the ECMO, is causing the gradient climbing very fast. If the gradient climbs higher than 50, then we alert team to prepare for the membrane.
So, do you think that we have to correct in each the factor and then try to prevent the membrane clot as well as we can do, right?
Yeah, because if we do not correct the breathing problem, the patient gonna die now.
Yeah, yeah.
Or if we go too far for the breathing things, then the patient gonna die later.
Yeah, or
Just keep it balanced.
or you overdo it so much that the patient, that you actually clot the entire patient. Yeah, you clot everything, and suddenly the circulation just stops. We've experienced that. Do you one other question? Do you have any experience with using a vacuum dressing in this situation with open chests?
I normally to delay the sternal closure, it depends on the patient size. If the small baby, I put celastic membrane and then put just ordinary chest drain, but I did not use the vacuum dressing. Yeah. But in the adult, close the skin, but leave the sternum open, and put ordinary chest drain. Yeah.
I have the experience for the vacuum drain, but not in the ECMO case, in the sternum infection case. In the ECMO case, if we have the problem breathing when we put the central ECMO, then in the adult, mostly I practice in adult only, do not practice in the pediatric. So we do not have a problem to make a cannulation on the axilla. We just graft, Dacron graft on the axilla, put the bio-glue in, and put the cannula in the graft. Then we can close the chest. Okay. I think it's time run out now. Thank you very much. Thank you every speaker, and thank you participant. Thank you.